Hi, Room Now. I'm Dr. Rachel Tate from ACR Convergence 2021, and today I am joined by our esteemed Team PSA faculty. You have come to know them throughout all of our reporting, and I wanted to take a second to really introduce them and to make sure that you know just how important and special they are. And today we're going to share one abstract each to tell you kind of our best of ACR for psoriatic arthritis. So I'm going to start with Pete. Pete, introduce yourself, please.
Hi, everyone. I'm Pete Castillo. I'm in Dallas, and this is my first year with Room Now, and I've just had such a blast. So thank you for having me.
We are happy to have you as faculty. Meral, tell us where you're at.
Hi, everyone. I'm Meral Ramahi, and I'm reporting to you from Indianapolis, Indiana.
Excellent. Thank you. And Antoni.
Hello, I'm Tony Chan. I'm a rheumatologist in London, UK, and I'm really glad to be with you all to join this session.
Thank you. We're so glad to have you. Olga.
Hi, I'm Olga Petryna from New York City. I'm very happy to be here, been with Room Now since the day it was created. So really enjoy this meeting and being with all of you.
Yeah, you've been paramount to our faculty from the beginning. And another person who's in that boat too is Robert Chow. Robert, tell us about yourself.
Hi, Robert Chao. I'm a rheumatologist over in Northern Virginia. Really excited to be here, and let's get the show moving so people from the UK can go to bed soon.
Yeah, that's very true. And then, of course, Richard, the prolific tweeter of the group.
I am Richard Conway from Dublin, Ireland, and yeah, a really enjoyable meeting, but glad it's over with the time difference so we can finally get some rest.
Yeah, I'm sure you guys are exhausted. You and Tony must be exhausted. So we'll jump right into it. We're going to start with Meral. Tell us some of your favorite, or tell me one of your favorite abstracts or sessions this year.
The one I'm choosing, there were a lot of great abstracts, so it's hard to choose, but the one I'm choosing I thought was potentially practice changing. So do any of you use Rapid3 in psoriatic arthritis to monitor disease activity? Well, abstract 0633 shows a strong agreement between Rapid3 remission score with DAPSA and CDAPSA when redefining the Rapid3 score categories. Rapid3 is a much simpler way to monitor disease activity, and so I think it potentially is practice changing to use this as a disease activity measure in our psoriatic arthritis patients. Of course, we need more studies to validate, but
of course. Well, I think it's really interesting because we often talk about how hard it is to categorize and truly understand disease assessment for patients who have psoriatic arthritis. I will tell you, I saw this particular abstract and said the same thing. You know, Rapid3 is easy for me to get. I already utilize it on my rheumatoid arthritis patients. Do you guys use it in RA?
Yeah.
Yeah. So I think it'll be interesting to see what happens and what comes from this. It's a good one. Robert, tell us about yours.
Yeah, sure. So I like to sort of branch off. You know, we see a lot of treatment sort of abstracts with the newest jackanid or the newest biologic. A really interesting study was 1362 when they looked at exercise and psoriatic arthritis. You know, I think that's a common thing. People ask me, what exercise can I do? What should I avoid? And they looked at stationary bike, and they used they had them do HIIT, you know, high intensity interval training. So actually about 4 or 5 sort of HIIT intervals 2-3 times a week for 11 weeks. So that's pretty decent amount of stationary bike exercise. And these are of course psoriatic arthritis patients. And interestingly enough, when they had MRI imaging, they did not find any sort of bone marrow edema pre and post in the HIT group and the sort of continue your daily sort of regimen as you will group, which is interesting. You know, I think a few things, it just rings true that we should continue to recommend exercise, even relatively high intensity. It would be interesting also to see in the future, perhaps a measurement, maybe like an ultrasound measurement of enthesitis. I would think, being in an exercise bike, perhaps more pressure on the enthesis. And all of those, have a lot of prospective roles here. But I think for me personally, I would continue to recommend exercise to my psoriatic arthritis patients.
Yeah, I think that is a really important piece of what we do when we teach and train our patients about their disease state and about disease state awareness. I can't recall, did they talk about BMI or even activity level pre-enrollment into the study?
Yeah, no, so the wording for that was a little bit vague. They didn't, the group that continued their standard exercise, we don't know what that was. I'm assuming, one can assume it was light, probably wasn't the high intensity interval training. But perhaps, some people were training more rigorously than others. BMI, I don't believe was measured or was a factor here.
I think it'd be interesting. Yeah.
I was going to say, I wonder too about if patients change their dietary habits. I mean, someone who's starting to exercise more and didn't exercise a lot before might also be like, hey, I'm not going to waste that by eating poorly. And so they may have also changed some of their diet. Did they talk about that?
No, but that's something I completely agree with. I think that's where I think us as rheumatologists, if we push patients to exercise more, I know if I'm on a bike for half an hour, I'm probably not going to grab that donut unless I feel real crappy. I'm probably going to grab a salad or something because I don't want to waste the half an hour of calories burned. And I know how difficult it is to burn calories on a bike. So I think there's a lot of sort of domino effect here. And I think the diet, we know half of weight loss is in the kitchen. It's not just in the gym.
When I think this is a pretty timely abstract, especially since, a lot of the stationary bike companies really blew up during the pandemic. So it was easier to hopefully find some of those patients, and it's important for us to inspire them. So Olga, tell us about your best of abstract from PSA.
So I really like the abstract 1783. It's a Canadian state study on the rate of hospitalizations for severe infections in patients with PSA. And then it was great to see between 2012, 2017, the rate of hospitalization for sepsis, UTIs, and soft tissue infections and skin went down significantly in patients with PSA, regardless of being on biologics and DMARD treatments, which probably speaks about, a role of good disease control in preventing serious complications. They didn't see a big improvement in pneumonia rates or hospitalizations for pneumonia, but still a good trend in all the soft tissue infections, UTI, sepsis, is something promising. It means something we're doing is right.
Yeah, I think that was really reassuring data. I would like to see this extrapolated out to the COVID-19 patient population. But again, we've seen a number of abstracts that kind of support that overall. We're hopeful that, of course, our patients do very well with COVID-19, et cetera. Anyone have any other comments on this particular abstract? Did you guys see it?
Yeah, I thought it was a really nice abstract. I think disease activity itself does predispose to increased rates of complications, even pre-surgery, for example. So it's very reassuring that the more we can treat their disease, the better the outcomes are. And I think that's also because we're monitoring them more as well if they're on these drugs. So they probably have closer care than if they were not on some of these biologics. So I think both of these factors are important.
Yeah, important. It's a really important point. Tony, tell us about your best of abstract.
Yeah, so we've been searching for biomarkers for years. And to me, I'm a simple rheumatologist. To me, the biggest biomarker is psoriasis, is having skin psoriasis. If you have skin psoriasis, you're very likely to get psoriatic arthritis in the future. And we know that we've looked into factors. I love a nice study done from Cleveland, 1798, where they had about 386 patients. And they looked at the presence of psoriasis and future development of psoriatic arthritis. And it was very interesting that if you develop psoriasis at age 42, your transition to PSA was 12 years shorter than if you develop psoriasis at age 19. So one wonders about immunological senescence, aging of the immune system, perhaps. But certainly the practical message, if you develop psoriasis in later age, be looking out for the joints. Maybe do a PES score, one of these scores, and screen them a bit harder because their onset is quicker.
So I thought this was fascinating. I know it's not the larger scale of what we would like to see for patients in terms of a trial, but I really think there is something to be said about aging. And there's been a lot of focus actually, and hopefully you guys have seen it, on aging during ACR convergence this year. Anyone else have any thoughts on this? Is this going to change the way that you practice or kind of think through patient cases?
I think it definitely will, make me pay closer attention, maybe obviously to the population above 40. I think the other interesting thing with this study is you look at the other risk factors and they didn't play a role. You know, the effect was dramatic with age. It was really dramatic. And also the other interesting thing was alcohol and smoking, zero role in progression of psoriasis to psoriatic arthritis. And I think there were actually a few other abstracts this year in terms of alcohol and smoking, psoriatic arthritis disease activity. And the role there was also mixed. Obviously, I'm not condoning, that, but it's just interesting to see this data with, especially in the psoriatic arthritis, because we know it behaves a little differently.
Yeah, absolutely. And we're still trying to find best measures and best practices. Pete, tell us about your best of abstract.
So I actually got into some of the axial psoriatic arthritis studies. There's plenty of things on this subgroup of patients this year. And one study that I liked that I wanted to share was 1796. It had to do with a simple screening in a prospective study where they took a bunch of dermatology clinics and basically asked them for a simple screening of patients that are adults that had 3 months of back pain or longer, starting before age 45, no biologics, and confirmed psoriasis and only psoriasis. So these folks were then referred. We ended up in rheumatology seeing 100 of those patients. And out of those, 14 of them had axial psoriatic arthritis, with 11 out of those 14 only having axial disease. And so I thought that was just kind of interesting because, when you see these patients with psoriasis, I mean, in the dermatology clinic, you want to make sure that these are folks that may not volunteer that they're having back pain when they're getting a skin check with their psoriasis doctor. So just kind of, and it was also a very simple tool. There was no need to go into whether it was inflammatory back pain or not. And so it was just basically straight up chronic back pain.
I
think that's important.
Yeah,
ahead,
I
Meral.
saw that as well, and I thought it was amazing because a very basic screening tool that we can educate our dermatology colleagues to put in place, even in the waiting room as patients are checking in, and just design a platform where it's easily available for them to refer to rheumatologists if they meet these screening questions. I thought this was a great abstract as well.
Yeah, I agree. Well, Richard, wrap us up. Tell us your favorite PSA abstract.
Yeah, so I love the tone of the abstracts that everyone's bringing. Actually, it's all very relevant to day-to-day practice. I think that's great. And likewise, I'm going to bring something similar. So one thing I do a lot in my everyday practice, use a lot of NSAIDs in psoriatic arthritis and in axial spondyloarthritis. And I give them to people. And so a lot of people raise the question with me, they've heard that NSAIDs, you shouldn't be on them for a long time. They've cardiac risks and other risks. And I usually tell them, don't worry about that. You're young, you'll be fine. And actually the risks are really, really small. But I always, in the back of my mind, I worry about it a little bit. I'm like, God, is this really going to be okay? Should I really be doing this and leaving these people on long-term NSAIDs? So there's a great abstract today. It was number 1920. It was from Hong Kong. And they had 200 psoriatic arthritis patients. And they'd done this time-varying Cox regression analysis on them. And looked at predictors of cardiovascular events in these patients. And what they found was that an increased CRP was associated with increased cardiovascular events, while NSAID use was actually associated with a decrease in cardiovascular events. So it seems to me the biological explanation for this is probably that the NSAIDs are reducing this inflammatory predisposition to cardiovascular disease. And so that's made me a lot happier about what I'm doing every day.
It's always reassuring when you see data to support it. So does anyone have any very quick last second updates for anyone who is watching this from home and who hasn't attended ACR? No, I think we're good too. So I will say thank you guys so much for all of your hard work, for your dedication to Team PSA. And as always, I can't wait to work with you again next year. And last but not least, feel free to continue to monitor for ACR Convergence 2021 updates at rheumnow.com.